evening once again to all of you. And hopefully over the next 35 to 40 minutes, I have two parts which Adaeze thought would be useful for all the audience here. One is around looking at chronic pain and musculoskeletal pain through the lens of lifestyle medicine, which is something I'm also a BSLM diplomate from 2020. And I believe that there is great value in some of the principles of lifestyle medicine and managing chronic pain. And with the research that I'm about to show you, I think it's even more necessary why lifestyle medicine plays such an important part. And the second part of the talk is going to be around how I have implemented some of those same principles in managing long COVID, because I work both as the clinical lead for pain medicine in my area of Berkshire in Reading, and I'm also the clinical lead for the long COVID service. So I'm one of the leads for one of the 90 sort of long COVID clinics that are there in England for looking after patients with long COVID. So the second part of my talk, I'll touch in that aspect over there. So I do have some other roles that I do. I'm on the advisory board for some digital health startups, but more importantly, I'm delighted to be part of a couple of patient-facing pain education programs. One of them is called Flip in Pain. For those of you who are not aware, this is a grassroots organization that is involved in educating the general public around pain science education. And the other one is called the Footsteps Festival, which is part of the Live Well with Pain website, which is again a fantastic information resource for people and healthcare professionals who are looking after people in pain. So what I want to sort of take up, would let you sort of take on in the next 20-25 minutes of the first part of the talk, is understanding the whole prevalence of musculoskeletal pain. And I think I'll touch on chronic pain overall, but musculoskeletal pain is something that as GPs and as members of the LM community, especially if you're working in primary care, that is going to be the biggest referral base to you when they come to see you with pain. And the challenge of the biomedical model, and I think the lens of lifestyle medicine, the opportunity. Now, Anita is a patient who was referred to me probably about 2017, 18 was when I saw her. But by the time she'd already had about 3 volumes of notes. This was when my hospital hadn't moved on to the electronic health record as yet. And at that point of time, her referral was for a diagnosis of fibromyalgia and further support. But in the 7 years prior to that, her first diagnosis was back pain, which she had at work. That back pain required some physio, which unfortunately didn't help. An MRI done at that time had picked up a disc bulge, so she was offered a discectomy. So she underwent a left-sided discectomy, and that left her with post-surgical pain going down the left leg. But unfortunately, rather than recognizing it as a possible post-surgical neuropathic pain, she was sent off to the hip surgeons for hip part of the pain and the knee surgeons for knee pain. And X-ray showed a sort of medial knee osteoarthritis. So she had a hip arthroscopy, she had a knee arthroscopy, she was offered a uni knee replacement of the knee, which didn't help. By this time, 4 years into her journey, she had not been able to go back to work. She was starting to have pain in her left shoulder and right shoulder. She was having neck pain. Her BMI had increased. She had become pre-diabetic. She was hypertensive. Mood had not surprisingly gone down, and she was diagnosed as depression on antidepressants. She'd been to the GI because of abdominal pain and got a diagnosis of IBS, and then pelvic pain because she went to the gynecologist, so pelvic pain. All of these labels, and finally the pain was generalized and widespread, went to the rheumatologist who said, you have fibromyalgia, and there she was in the pain clinic. So this is a typical example of a reductionist paradigm that the biomedical model really puts on. Many of you may recognize the various Anitas that you have in your practice, that you feel and felt through. And it is a challenge because we understand that that kind of an approach really doesn't serve our patients well when we all just look at it from our individual expertise. Because the reality is actually that the medications for pain, and painkillers really, while I put that word there, is a word that I don't use in my regular practice, work only 30% of the time. Any injections at best last only about 3 to 4 months, and barring some few ones that are there, but by general, this is the rate. There are studies to actually say that less than 10 to 12 hours of pain education has been provided to most of our clinical health practitioners at this time. And the studies have shown that it's in a 6-year period of medical education, you get about an average of 10 hours of medical education devoted to pain. So that is a real challenge there, that most pain specialists are not really aware of the advances in pain science. And we all know, a lot of you are going to be general practitioners, and you will know that the question is, yes, they see us for 10 to 20 minutes. What do patients do? And a lot of what we want to do in lifestyle medicine community is to actually encourage them to start taking some ownership of their health. And specifically with musculoskeletal pain, there's a lot of treatments. There are lots of things that patients will be faced with, and we really don't know, and they also don't know which treatment to choose. So the biomedical model we're realizing is not really a sustainable model at all. And because of all these variations, we really need to look at the burden of what we are faced with. Now, the cost of caring is really massive. 10.2 billion is the data that suggests there. 1 in 7 GP consultations are apparently musculoskeletal pain. And you can see that these are, spread across the entire lifespan of anyone coming and visiting healthcare professionals. In fact, more people suffer from MSK pain than all of diabetes, stroke, and heart disease put together. Take note of that there. I've just gone onto the websites of these 3 places and found out, and they don't really come up to the 20.3 million that we're looking at. Specifically with back pain, for example, and that's a challenge that we really wanted, because we now are talking about a healthcare system. This study came out in 2019, which actually talked about what is it, the problem with just looking after one part of musculoskeletal pain, just back pain alone. And they noticed that actually the way the health system is structured, the financial interests that are there are really a big issue of it, because how you get paid for what you do runs the system. But the other 2 things are quite really revealing aspects there, is that you've got this deep-rooted medical tradition and beliefs about what causes pain. And that is something that is generationally a problem with how the public has been brought up to think about pain, and how healthcare professionals also are thinking about pain. And that is a big issue there, because the payment systems automatically accompany those beliefs and only favor medical care over trying to get patients to think about confidence and self-management. And I think this change, this understanding that we need to inform the public, has been something that has been at the root of what I wanted to believe in and talk about in the last few years. And so a lot of the work that Flip in Pain does in terms of grassroots pain science education aligns with what I think is very important. And in fact, my book as well, which I wrote and got published last year, essentially is aimed at the general public and at lots of patients and healthcare professionals, just trying to make it as simple as possible in terms of understanding the new science and the opportunities it then provides us in managing it. Because this reductionist paradigm is really not helpful if you want to go there. That paradigm is very much a hand-me-down from Descartes, who's a French philosopher that some of you may have heard of. What he proposed was fantastic in the 17th century in terms of a mind-body dualism, because it allowed for the first time the body to be taken apart by doctors, and those kind of understandings really spurred the medical advances for which we are so thankful. And in fact, his primitive model of pain as well was very much a model of wires that seemed to spread from the area where the fire was, and that wire would go along, and there would be a gland at the back of the head called the pineal gland. And whenever somebody felt pain, he proposed that the wires would go along, activate the pineal gland, and that would open humors, which would pull the muscle away from the fire. And you can see that that kind of a separatist, very mechanical approach made us believe that with pain, you can actually cut it, block it, numb it. Any kind of pain should have a physical cause that should be cut, blocked, or numb. And that really spurred on a lot of the advances that's there. And the reality is that that Cartesian model does not work if you do not understand the real need for pain. Nothing in biology will make sense if you don't look at it from the light of evolution. And the question to ask is, what does pain signify when you look at it from the construct of why is evolution wanting us to have pain as an emotion and a sensation there? So the Cartesian model is very much an outdated model, and I don't think it really serves now. Instead, I would probably encourage you to take a sort of 30,000-foot view, look at it from the bigger picture there. And for me, that really made sense to start looking at it from a much bigger picture, to understand the why, what, and how. We always think, oh, yes, we should treat pain, we'll just do the stuff that's there. But I think it's important to ask the upstream questions of how do we treat pain, but what do we treat pain with? And most importantly, why should we be doing it that way? And so the first aspect, which we are all very familiar in the LM community itself, is that attention to the social determinants of health. We are very aware how that important plays in understanding and treating pain. And to me, the model that I bring about is what's called trauma-informed care, as a way of understanding how social determinants of health play a role on why pain will present itself. So that part there is essentially looking and understanding the same, reimagining pain as not just a biopsychosocial phenomenon. In fact, I think of it as a socio-psychobiological phenomenon. And I've taken off the lines inside there to indicate that we should not be separating it. Often we talk about it as biopsychosocial, but then we have separate people doing the biology, then separate people doing the psychology, and the social often just gets lost in there. But what we know is actually only 20% of what we do in a traditional healthcare setup when patients come to see you in your GP practice or they come to a hospital for treatment, all of that in terms of wealth and health and well-being is only contributing to 20%. The remaining 80% comes from a combination of the socioeconomic factors, the physical environment, and the health behaviors. And that was really a big eye-opener for me in my pain clinic there, because often patients, when they come to see me in the pain clinic, I'll feel like somebody standing at the foot of a waterfall trying to rescue some people from the waters around there after they've fallen off. I'd be able to rescue some people. I'd be seeing them 6 or 7 years after having struggled with pain, gone to different people, and then come to me. And by that time I can do something, they are often so helpless and feel so hopeless that trying to get them to feel confident that they can overcome their pain is a very tall task. And over the last few years, I've made that attempt to go upstream to actually say, can I work with primary care colleagues to actually see if we can prevent patients from falling off the waterfall? But a more important and a necessary question is, how much more upstream can we go and ask the question, what can we do to prevent those people from being thrown in the water in the first place? That's very important to understand there. And to me, one of the eye-opening and game-changing pieces of work and literature that came through is this concept of trauma. Not the orthopedic musculoskeletal trauma that we all think about, but actually to understand and review and look at trauma from a different perspective. To say that if something happens which is unexpected as far as the person was concerned, the trauma itself was unexpected, and the person did not have the agency or the autonomy to feel that they were in control of it, then what happens inside of the body when trauma happens to you, meaning what changes in your immune and nervous system when that kind of trauma is felt, that has a real implication on how pain is perceived and amplified and present. Because once you take that view, you can then look at what are big trauma or small trauma. The big traumas like major road traffic accidents, major surgeries, major ICU care, the kind of problems that we've gone through with the pandemic, but also then the small trauma, the changes that happen with bullying, workplace, isolation, neglect. All of these have an impact on the nervous and immune system at any time of our lives. But the earlier the impact occurs, the earlier the influence of the nervous and immune system has you experience these traumas, then a more significant change occurs in the whole system itself. And that's where the concept of adverse childhood experiences really was a sort of big opening for me to understand a lot of chronic pain in there. Now, this study, the Adverse Childhood Experience Study, many of you may be aware, but this was a landmark study in the US in the 1990s, where a GP worked with the CDC to ask these 10 questions of his 17,000 strong practice. And what he found was that more than 25% of his practice had answered yes when they were asked these 10 questions around abuse, neglect, and household dysfunction, meaning that had they been subjected to any kind of these before the age of 18, then 4 or more such adverse experiences were agreed to by 25% of his population. He then repeated this in many other parts of the US. It has been done in Scotland. Scotland is an ACE-aware nation, as I understand it. So it is a very strong force in the country itself, which is fantastic. And then this has been replicated in many parts of the UK as well as many other countries. And the data is remarkably consistent, that when you have 4 or more adverse experiences, you have a significant element of other physical health conditions and mental health conditions being much higher than the normal population. In the chronic pain setting, 3 times, almost 3 times higher chronic pain and probably musculoskeletal pain than someone who hasn't had a single adverse experience in childhood, or probably 1. And in fact, adult victims of childhood maltreatment have greater MSK pain problems, have other organ systems that are impacted, and they end up going to multiple specialists for different diagnoses. The reason I say this, remember Anita, her story? When I had the rapport and I knew of this research and I asked her in 2019, what do you feel, would she agree to that? She actually said that she had 9 out of 10 adverse childhood experiences ticked off there. You can understand what was her nervous and immune system like when all of these things started to happen. And what do I mean by physical health conditions? You may be already thinking, or there may be a bias saying, okay, that's all mental health, probably understandable. But look at all on the left side here, look at all those health conditions here, which we very much understand as physical health conditions. And look at the significance, the clinical significance when you have had 4 or more adverse childhood experience. So this is really significant in terms of not just chronic pain, but also in so many other physical health conditions. And that's what I want to point out there is so much of adversity that our patients bring to us when they come to see us in the clinic, which will be having an impact in their immune and nervous systems. And that will be having an impact on how they then respond consciously and subconsciously to the way we talk about their pain, to the way we investigate their pain, to the way we medicalize or over-medicalize their pain. So becoming trauma-informed is actually about not asking the question, why are they like this? And why has somebody, again, a heart sink come to our clinic? But to actually reframe the question and say, what might have happened to this nervous and immune system to be so overprotective? To recognize this, because once you've recognized this and applied the principles of trauma-informed care, you are going to be having a more important reason for validating their concerns, listening to them, calming the nervous and immune systems down, because that can mean reduced tests, reduced procedure, and hopefully iatrogenic harm. Ultimately, you want to then spread this message along with the rest of the colleagues who are looking after the patient, because then your communication is all aimed at resisting re-traumatization. We don't want to be saying something that actually frightens the immune and nervous system when they're already hypersensitized. And that's where the what then comes. Because once you've calmed the nervous and immune system down, how do you then go about talking to them about what else can they do to maintain that calmed nervous and immune system down, if drugs and interventions are really not going to be the answer in everyone? And the pillars of lifestyle medicine are hugely relevant in that part there. And I certainly go through in great detail in the book itself, wherein I don't want to throw the baby out with the bathwater. So I think there is a role for medications and there is a role for interventions such as surgery or injections or infusions in appropriate times. But it really isn't to the extent that we've now adopted in the biomedical model. Certainly, I'm happy to go into the research on there, but we know that that is not serving the purpose. In chronic pain management and musculoskeletal pain management, there is so much concern with the medications that we're talking about, with the challenge around opioids and gabapentinoids, and with injections as well. We know arthroscopies have no evidence. We know that a lot of shoulder and knee arthroscopies are excessively done with no benefits there. Because ultimately, what I want to tell you is pain is a form of an evolutionary alarm system. It's an excellent protection system. It just isn't that accurate. what effectively some studies over the last 20 years have proven. So for example, this study that came across in the toenail part there. This was a study that was done in 1995. A builder jumped from a top of a 3-meter platform, I think. A 3.5-inch nail went through his boot, as you can see on the picture here. He just couldn't be controlled on the building site, nor in the ambulance, nor in the emergency department. Had to be taken to theater, given a general anesthetic, and then gone off to sleep. The surgeons all ready to scrub and clean there. And then when they decided that they would take the boot off and clean the wound, what do they find? There's no physical wound at all. The nail had gone between the big toe and the first toe. So really, we know that there is no correlation between injury and the pain experience. And our understanding of the brain now and pain as well is that it is a prediction machine, but it is a prediction machine which looks at the context and decides that it needs to protect you. And that's what it's trained for. I'd urge you to check out this YouTube video called Tame the Beast to understand it better. It's just a 5-minute animated video, something for your patients as well that will be really useful. And that also informs the new guidance that came out of NICE last year, which will be part and parcel of what you are having to do for your pain patients. And they talk about this concept of primary and secondary. Now, for some of you who are a little bit confused about this and might have still heard conflicting areas of information about what primary and secondary is, primary pain is a brand new concept and a construct. It was just introduced in 2019, and effectively it covers an entire block of conditions where pain can be out of proportion. And what they wanted to specifically move away from is not to have a psychosomatic presentation, which is often a way of thinking about it, but they said chronic primary pain can be any of these things: non-specific low back pain, fibromyalgia, migraine, IBS. All of these are forms of chronic primary pain. Obviously, there is a secondary pain as well, and that can be any of the pains that come after a trauma or surgery or cancer or visceral pain after surgery. But we are saying that primary and secondary can coexist together. And the new definition of pain that came about 2 years ago actually makes construct of that to say pain and nociception are different phenomena. I'll want you to urge you to sort of look at that aspect of the second point, pain and nociception being different phenomena. What do I mean by that? They want to actually insist that when you have an injury or an inflammation or a surgery, chemicals are produced at the site of that injury or surgery. Those chemicals are converted into electrical signals. The process of injury chemicals being converted into electrical signals is nociception. Now, nociception can occur in everyone, will occur in everyone. But when those electrical signals then reach the brain and the spinal cord, the brain then has to do its prediction, context, processing, and finally, decision of protection. When it decides that it has to protect and it has to bring about the experience of pain, that's when that whole understanding of pain experience comes along. So pain and nociception are two separate things, and they are not the same. But in the traditional biomedical model, we have always just conflated and used both. The reason this happens, the prediction and protection, is within the brain. There are multiple areas of the brain that work like neural networks that keep changing and wiring and rewiring and firing differently. And each of that is brought about by this newly understood concept of neuroplasticity. Each of you listening to this talk now will have had some neurons firing and wiring differently to take on this information. And that's how we learn new skills, and that can go on. So this neuroplasticity is something that we need to enhance there. But more importantly, what we've realized is that this kind of wiring and firing can occur increasingly in many places. And that's what nociplastic pain, that particular kind of pain that happens when the nervous system gets wired up repeatedly and amplifies the pain because it wants to protect and overprotect. That whole group is called nociplastic pain. We've still got the nociceptive pain, which is when you have an injury, and you've got the neuropathic pain when you've had nerve injury, diabetes, MS, Parkinsonism, so many of those conditions. So the reason we want to distinguish is that when you can have a clear-cut idea of nociception, your CRP is high, your ESR is high, there's inflammation, there's surgery, then you can bring in your medications and interventions. But when you've got the pain experience, which is always going to happen, we should not forget, and if not anything, we should be giving equal importance and more importance, maybe, in my view, to all the other aspects of lifestyle medicine related aspects, because they can be sometimes much better than the medications and interventions alone. So that's why my whole purpose of coming to you with saying that if you can bring those elements of lifestyle medicine through, that has a much better chance in helping your patients, because you can then move away from the drugs and the interventions alone and encouraging them to take on so many of these things. And in the book, I go through so much evidence-based reasons for why we should be looking at the other 5 and not just stopping at the medications and interventions alone. Because interventions, for example, just take the interventions alone. There are now studies to say that people who have no pain at all, but their hips, knees, and shoulders are subjected to MRI scans, will have labral tears, will have meniscal tears, will have degeneration already showing up on their scans, but they won't be in any pain. And there have now been studies, randomized, double-blind, sham-controlled studies in interventions that have been done, which show that there is no change at all and no benefit over sham surgeries for knee arthroscopy, for shoulder arthroscopies, for tennis elbows. So realistically, we are getting to know that there are no benefits for some of the surgeries at all. And I talk a lot about the brand pathway, which I can go through. Lastly, I'm just going to cover on the pain management programs and group consultations, which is a very popular thing in lifestyle medicine there. But the behavior change skills is what we should be doing. Harnessing neuroplasticity is what we should be working with our patients on. And actually, it's not about just setting goals, but ensuring that they have the system to carry out through at a group or individual level. And that's where I think the lifestyle medicine course actually makes a big difference, because we can be a lot of these things in helping out. The second part of my talk is a little bit of a more rapid run through with long COVID. And I'm just going to go through. Many of you may be looking after patients with long COVID or there. I know that for many of you who are in Scotland, I'm not sure you need to tell me about what the state of the art is in terms of long COVID clinics or what's happening. But for us in England, we have been lucky to know that there are 90 such clinics around to help and access patients. But waiting times are a big thing. We are looking at 2 million patients in the UK struggling with long COVID, or 15,000 per specialist service, or 40 patients per full-time GP. Apparently, that's the numbers. But there are a lot of UK health workers also affected by long COVID itself. Long COVID, from my understanding, is a multi-system and a multiple symptom problem. There's been no association with severity at all. The natural history is very much unknown. It's evolving really. And we've been really informed by how patients really react and talk about it on social media and when they come to the clinic. The problem is quite big, 3% of the UK population. And the main reason is that with the kind of patients that have been coming through, all between the ages of 30 to 60, it actually is a public health crisis, because there are labor shortages happening because of all of this. There is a lot more understanding now in terms of who it affects, what it affects, the comorbidities that are present over there. And the symptoms are something that we've been seeing in other groups as well, fibromyalgia, chronic fatigue, and there. But there has been increasing studies to look at saying, well, what else could be happening? And for the first time with conditions like long COVID, we are realizing that sometimes as much as 200 different symptoms get reported over 10 organ systems. This is not something that our medical schools have ever trained us in to understand or to really make sense of and decide what should be the treatment. These are the kind of symptoms that patients have come to my clinic also complaining about different organ systems. And it really is a challenge in terms of saying what should be investigated, what should be supported, what should be managed. My service is a secondary care service. About 70% of services in England are mostly in the community. So ours is one of the rarities that is in secondary care. But we are integrated with the community service. We have other options to work with. And we've realized that there are physical, cognitive, and mental problems that affect patients. The most common symptoms obviously being fatigue, pain, shortness of breath, mental health issues, GI, cardiac symptoms, autonomic changes, dysautonomia, loss of taste and smell. And right now, the NICE guidelines very much talk about lots of living diagnosis, no blood tests or imaging specifically for the condition, but they are insisting that after 12 weeks, patients should be referred to a long COVID service, and up to 12 weeks can be managed in primary care. We are realizing that in terms of causes, there's an immune system activity, there's a nervous system overactivity, there's some research coming out around sticky blood or microclotting there, or is there a latent reactivation of Epstein-Barr or viral presence there? We know that there is people more at risk of long COVID, people who have asthma, diabetes, age, mental health issues, autoantibodies, all of whom have known to have a higher risk of getting down with long COVID. But the treatments right now, we don't have any. I know that there's a lot of talk on social media, but as far as the NHS is concerned with what we are trying to deal with, we just accept that this is going to be a long-term condition. But at this time, in most long COVID services, we are just being aware of the case definitions. We're providing support for acute COVID, recognizing the symptoms, trying to refer to personalized care and get MDT services in there. And I probably refer you to these two books that have come, both for your patients and for yourself. One is from the Oxford group, one is from the YouTuber called Guess Medinger. And this particular article called the Draw on Expert Opinion to Optimize Care, excellent work by the Harsha Masters and Ashish. And they go into great detail on what should be done in primary care to look after these patients in terms of testing and when to refer patients in, and also talk about how do you associate and give trials of medications and what can be suggested to patients for mast cell changes, for dysautonomia, for menopause-related issues. From my perspective, I've tended to look at long COVID again from a lifestyle medicine perspective to say that there may be a role for medications, there may be a role for infusions or interventions there, but I really think that talking to patients about understanding their problems, why is it happening, looking at a diet, an anti-inflammatory diet, focusing on the simple things around sleep management, physical exercise, activity carefully to prevent post-exertional malaise, and mind-body therapies. There's a lot of research happening, and I can talk about that in the Q&A, but there's a whole lot of stuff happening both in the US and in the UK. And in fact, just as recently as October last month, the WHO has recognized that we need more understanding and more research for long COVID itself, because we don't have a fix for this right now. Thank you for listening to me. Any questions, anything at all?
Wow, thank you so much, Deepak. That was great. Thank you. So much to cover. I noticed you were rushing right through because there's so much to cover. Thank you so much for that. There is a question in the question and answers. I have some questions myself, but let's see what others. If you have questions, please put them in the question and answer chats. So there's one there, Deepak, and it says, any associations between long COVID and vaccination status? That's the prevalence, severity, or is this not being monitored? This is not being monitored? Monitored, yeah.
This is a very hot topic, and I think it has its share of controversy as well going on. I have had a number of patients to my clinic who are absolutely adamant and very clear that their long COVID-like symptoms started after vaccination. So they've had a very mild COVID infection, or they've had no COVID at all. But after they've had the vaccine, they started to experience symptoms which are very similar to long COVID, and they get referred to the service there. I've had people with a few vaccine-related injuries as well. So I've had brachial plexopathy, I've had sciatica changes, I've had neurological symptoms that have come on after that. So I think there is a group of people in whom the vaccinations have not been the right thing for them, because it has triggered a different change. Ultimately, Adaeze, I probably, to the person who's asked the question as well, we want the vaccines to trigger the immune system to be ready to handle the actual infection. So we do want the immune system to be eventually prepared. But what we can't predict, and I think even before COVID came along, whether it was flu or many other vaccines there was always going to be that percentage of people who reacted badly to vaccines. And what I don't know is whether we are seeing that same proportion of people. Obviously, when you vaccinate 1 billion or 1.5 billion, are we seeing a similar proportion of people reacting badly to vaccines?
Yeah.
Or because the mRNA technology is a new technology, we are still trying to understand what, because in a way, these are all phase 3 studies of the mRNA vaccines. Are these post-marketing surveillance data, which data should come out on how people respond to these vaccines itself? So I think I am not part of any group that is monitoring vaccine injuries, but I know that this is a very active talk, and I know that there are campaigners like Azim Malhotra on social media and nationally who are very much of the view that vaccination should be paused or it should be reviewed because there is the unacceptable rate of problems after some vaccines. So I think watch this space is what I'd be telling a lot of people.
Thank you. Yeah, so Julie, did you have a question?
I did actually. Thank you, Deepak. That was absolutely fascinating and really, really helpful, I think, as well, as in certainly my line of work personally. One of the things I guess I was going to ask is, I find it quite interesting how you were talking about a lot of chronic pain and the association with, perhaps trauma in people's lives. So bringing that back to long COVID, and certainly a lot of people, when they have long COVID symptoms, we're investigating them, we don't tend to find any actual pathology or abnormality. So I guess it's just, is there anything, this is just a thought, anything or any research looking into the possibility that trauma could be contributing to people's symptoms, the traumatic experience of the pandemic, and a lot of people lived in fear for so long of getting COVID. So when they did get it, people were terrified. Is this it? Is it going to kill me? Am I going to get through this? And they have. So people who have trauma possibly contributing to chronic pain. Is there any evidence that trauma of the pandemic is contributing to people's long COVID symptoms?
I believe that there is. I believe, great question, Julie. I believe that there is some research. I'm aware that something is being looked at in the same way in the US, looking at the background and seeing whether there is an increased amount of ACEs on there in some of the long COVID clinics. Not sure that anything is going on in the UK of that nature. That we haven't been. So the only reason for the adverse childhood experiences or trauma literature with chronic pain and so many other conditions is we've had 20 years of that papers and research produced there. I think with long COVID, it's still early days in terms of getting the cohort of people to then ask the questions to come back. But I would be probably of the opinion that it will have a percentage of people where if the nervous and immune systems have already been super sensitized because of a variety of experience from before, then something like COVID or the pandemic itself might be just that traumatic experience trigger to push it over the edge.
That's true.
I agree. I mean, that would almost be my sort of personal observation, but it's really difficult to try and get that across to patients without them feeling you're insinuating it's in their head. And we need the long-term research to validate that there is a genuine correlation with the two, before we can then help address that and manage it with patients. Because at the moment, they still are looking for some physical evidence.
Absolutely.
I think right now, I would agree with you. I think right now there is so much stigma and so much of disservice we've done to people with chronic fatigue, with ME, with even conditions like fibromyalgia in the past, in terms of how we've looked after or understood those conditions, that there is a very real push from the long COVID community to really investigate this as a biomedical condition, to really look deep into the microclots and develop new techniques and new medications or new treatments. So I think at this stage now, they will all accept that, yes, their nervous systems and immune systems are out of kilter, but there is still a desire to have a treatment or some kind of a technology to bring it back to normal rather than to just do this. So I would agree that it's not something that I'm trying to actually even. So my long COVID patients there, I completely, first of all, just validate their experience and what they have gone through.
Yeah.
I tell them that what you have gone through in the way the virus affects their immune system and nervous system is very much real. The research that I'm involved in does show that there is some neuroinflammation that occurs with the virus in the immune system in the brain, and that might be responsible for a lot of the brain fog, a lot of the fatigue, a lot of the memory problems, as well as other symptoms that they experience. So that actually makes them accept that even though these are things that are happening in the head, it is the neuroinflammation that's happening within the head that's causing the symptoms, which makes it quasi-biological, which at least gives it that credibility that they can say, okay, this is someone who believes, this is someone who accepts it, rather than saying it's all in the head.
I think that's an important point. You know, people want to be validated because they are feeling what they're feeling. So even though all our tests are negative, we can't see anything. They're feeling what they're feeling. So like you said, someone who believes them, yes, you're feeling this, you know, it's so important to patients. There are a few more questions around ACEs. So I'll just quickly read those out. Deepak, this one, this person says, could you give us some tips for asking about ACE in GP consultation? Let me lump it together with all the ones on ACE. It says, can we undo these traumas? What treatment would you recommend? Any evidence for meditation, mindfulness, CBT? And the last one on that says, if you have patients with ACEs and chronic pain, do you do any work concerning those trauma? I guess in your clinic, if they came and had all that, what do you then do? How can you reduce the influence of ACEs trauma on their current pain?
Fantastic series of questions there, Adaeze. I will try to answer them, and if I've forgotten something, then please remind me again. So in my chronic pain service, everybody who gets referred to the pain clinic in my NHS service fills out the ACEs questionnaire. So it is a screening measure that we have in our clinic. I think I'm the only service in the country that has that secondary care service that does that. It's given me great insight into putting that there. What can I say from there? Patients don't refuse it. They don't get angry about it. There is a paragraph that accompanies it, which is exactly what I told you, that we understand that ACEs increases the risk of chronic pain. And so we just want to find out. So it is as non-threatening as possible. It is something that they divulge if they want to, and they do it. And we haven't had anybody refusing it or getting cross at being asked that when being referred to the pain service. If anything, then during the consultation, if it becomes clear that they have 6 or 7 ACEs, but they have this series of, like Anita, they have a long series of lots of investigations, lots of diagnoses, lots of labels, then it gives me a way to say, well, you know what, you've tried all the medications, there are no injections there. Do you understand that sometimes we are dealing with a very sensitized nervous system, immune system, that we have to calm down? And if the drugs don't help, these are the other things that we can use to calm it down. So that at least gives me a way to actually introduce it in a non-threatening manner, but also then guide them to the next step of why I think those kind of mind-body therapies could be helpful in managing it. Now, do I really need, unless and until the ACEs themselves, they start to volunteer the information that I had this happening to me, sexual abuse happened to me, and that's why, and I need help for it. At that time, I would refer them to the trauma service that in our area there. But realistically, I don't intend to treat their ACEs at that point of time. That is never an intention to treat them for their ACEs. What I use it for is 3 things. One is that it creates a sense of awareness in how we communicate to them. So my language and the way I communicate to them is much more careful and nuanced. It gives me an indication that when I have to talk to them, I must not frame things too much in the negative context. So if I think about a drug thing, telling them that the drug is going to kill them or the drug will cause dependency or addiction is probably a negative frame that will make them worried and wire up their nervous and immune systems into a negative spiral. but it's about the positive frame. What can you do to go forward to something rather than frighten them? So that is one thing. It also gives me a cautionary thing there that in these people, I would be, if I had to suggest, so it's not that I won't give them any interventions or I won't try opioids or anything, but it'll be more careful. If I'm going to suggest an opioid for somebody who's got an A score of 5, who says that they don't have a physical support or resilience, or they're alone and they have no social support, they're on their own, then I would be writing to the GP and I would be telling the GP that this person has got an A score of 5 as per the questionnaire. However, we've tried other things and we want to try an opioid, but because of his sensitized nervous system, we would be wanting to ensure that we do a very careful 6 to 8 week trial. We want to have a clear evidence of benefits of the opioid. And if this is not done in 8 weeks' time, then we should stop the opioid and not leave. So there are very clear boundary constraints for both the GP, for myself and the patient. And the communication with the patient also is in such a way that we don't want to leave them with something that might cause harm, but we want to just trial this to see how it will help. So that is how I tend to use the ACE questionnaire findings in my consultation, in my discussion around interventions, in my discussion around opioids, because that would be the evidence. If people have high ACEs and they don't have a social support or resilience system in place, that's when the problems of other problems of dependency, addiction, and all of that can happen. Because ultimately, even with addiction or drugs or anything like that, my view is that whether it's pornography or whether it's donuts or whether it's chocolate, we use these things to calm down our immune and nervous systems when we are distressed. One group of people will choose opioids because at that critical phase of time, a drug will provide that solace and distress relief, which for other people would be shopping or retail therapy or donuts or things. So ultimately, the reward system in the brain that responds to this is the same in all of us. Some of these patients have just had a sensitized nervous and immune system right from childhood, where they haven't had that kind of distress relief from someone close to them. And that's how they're acting out now in their 30s or 40s. That's not their fault, but it's just the nature of the system that is just reacting to support there. The last bit that you asked me about with the ACEs part there, I think, have I addressed all the questions? Is there something?
I think you have, yes. Someone is just worried that if you're discussing it with them, it says, how do you discuss it without scaring them that they're physically and mentally screwed? I think I like the idea of the questionnaire, and it would be good if you can give us that question, pass it on to us somehow. I haven't seen that sort of questionnaire.
Because it's a standard 10-question questionnaire that's there. That's what I'm saying. This is standard practice now in social care systems. This is standard practice now in justice systems. This is standard practice now in housing care systems. Why is healthcare being worried about it when actually this is the standard of care in about 15 to 20 US states, and Scotland is an ACE-aware nation. So in most of the criminal justice, social care systems, and everywhere, this is standard practice. This is how people are doing it. For example, in the state of California, everybody has to go through these 10 questions because it just makes all the healthcare professionals a little bit aware of that. So I actually would say that we are not scaring them. This is something that almost just becomes about raising awareness that there is something else in the background contributing to a sensitized nervous and immune system. That just, I think it makes it, and I think you're absolutely right there, that it feels worrying to us. In fact, my psychologist in 2018, when I wanted to test this out in my secondary care pain service, they were all worried that this will open up Pandora's box and, oh my God, what do we do? But actually I said, let's trial it out. Let's do this for 10 weeks. 140 people were answering the question. Only one person asked us why we are doing this. The remaining 139 members of the public who came into the pain clinic had no problems at all. We're glad that somebody actually were interested enough in the whole person they were. So actually, that's why we were able to introduce it as part of routine clinical entry to the pain service in 2020 after the pandemic is done. So I completely get that there are a few GP practices in England who do have it as standard care at the time of entry into the GP practice. So there was a poster that was put about 2-3 years ago. The one thing, so I probably would say, if you go on YouTube and you look at the thing called the care method by Bob Monder. These are two psychology/psychiatry colleagues, and they did a YouTube video of the care method in asking about ACEs and why that can be done easily in primary care as a way of doing it. So just for you to check out that, I can give the link to that YouTube video while you ask me the next question.
Thank you.
I think just to back up that point, I think we are moving forward with that a little bit. You know, someone did mention, I can't remember in the Q&As or the comments, you know, I kind of proposed, are we just a little bit behind some other countries with it? And perhaps we are a little bit, but I think it's coming now. And I think sort of post-pandemic, people are a lot more open to discussing, you know, their personal experiences, their emotions, their feelings, accepting, you know, anxiety, mental health issues. So I think it is coming. We're definitely moving in that direction. So I guess I'm aware we're tight for time, so we can maybe just there's just another question we could pull out here, and I suppose it's pulling it back to the topic that, you know, that is the core of all this, is lifestyle medicine. So somebody's asking really sort of what, when we're actually dealing with some of these patients with chronic pain, in particular cancer pain, and things like, you know, opioids and things aren't effective, what sort of lifestyle approaches are effective as an alternative, and what sort of things would you, I mean, I know you touched on sort of sleep and nutrition, but you know, what sort of things can you give us a bit of advice on how we can sort of deliver that advice and coach our patients in that sense, or manage them with these techniques?
So I think there is a lot to be said for the group consultations method that seems to be becoming quite popular both in primary care, and I know that BSLM have been really looking at it as an option, and that can be a perfect vehicle to actually deliver many of these techniques of lifestyle medicine for chronic pain patients. I think the first thing is that we need to accept that drugs and interventions have some validity and place in them at some point of time. But if we can teach patients about, you know, nutrition, there's so much to be said about the anti-inflammatory diet, about what can be brought there. So I'm aware that in one of the local GP practices where they did a group model. So I can just describe the model that we practice there. So we did a 6-session module for patients with chronic pain in a GP practice. So the GP was also a lifestyle medicine diplomate, and she had, with this additional roles and responsibilities, she had a counselor, she had a nutritionist, and she had a physio as part of her practice itself. And what she did was we brought together and we invited about 15 or 20 patients in the clinic. And the first session was me coming and doing a talk similar to this, trying to put a frame for saying why we need to have other strategies to manage the pain. The second session was the nutritionist talking about the anti-inflammatory diet. The third session was the counselor talking about sleep methods and other mind-body techniques around mindfulness and their practices. The fourth session was around physio and physical activity and movement-based techniques that can be helpful with chronic pain management. The fifth session was a little bit of around, I think she had someone for 1 or 2 topics that were not covered, things that patients brought up during the first few sessions to come through there. And the sixth was a bit of a recap and capture on there. All the 15 people had their own WhatsApp group to continue conversations after, and they were all sort of close by. They could meet up afterwards to go for coffee or a tea or something on there. And they had an open session or a drop-in that they could come back and have in there. So I think that kind of approach meant that, yes, it was not that they can't get. And then if some of them during third or fourth session, oh, yes. So the pharmacist was the other model there. And so if some of them felt, you know what, I want to reduce my medication, I want to change my medication, I want to look at it there, the pharmacist would be advising them on how to start deprescribing, how to come off there and use the help. So that was a typical model in which we could look at implementing some of those elements of the lifestyle medicine approach in a group consultation level using lifestyle medicine principles in sort of primary care. I think that probably would be the way there. I think the evidence there is, when I look at the evidence for medications and interventions, I probably say that the evidence for things like yoga, for mindfulness-based practices, for some of the mind-body techniques are definitely as good as, and in some places, at least they are not harmful and they don't cause iatrogenic harm like medications and interventions. So I definitely been supporting them there. And I think somebody in the questions asked about the work of Howard Schubiner or some people in the US who are doing that. I'd say that those are the techniques we should be looking at and seeing how we bring that in the UK in terms of harnessing neuroplasticity.
Okay, thank you so much. Maybe one or two more questions. There's so many. Someone is asking, are there anything that we can recommend to patients generally in the immediate aftermath of COVID to reduce their chances of developing long COVID?
Just repeat that for me, Adaeze, again.
So people who have had COVID, are there things we can recommend for them to do once they've had COVID so they reduce their chance of developing long COVID, going on to have long COVID?
Quite tricky, actually. The way I tend to think about it is actually I do a lot of suggestions around nutritional supplements. So I encourage them to, because ultimately what we are saying is the virus has caused a sensitization of your immune system.
Yeah.
It has caused a change which could potentially go on to sensitize the nervous system. And it is this combination of hyperactive immune and nervous systems, which is what is causing long COVID-like symptoms. So if you are asking, what do I do to prevent it or prevent the immune system from becoming or staying overactive, then what can I do to calm it down? And so it is with that mechanistic approach that I suggest that, okay, can we think of ways when you're recovering from the acute COVID or when you're in acute COVID, focus on a lot of nutritional things. So increase vitamin D, increase vitamin C, quercetin, coenzyme Q10, alpha lipoic acid. So I talk about a few of these supplements there. And then I suggest that in terms of techniques, I encourage them to say, what are the other ways to calm the immune system? So encourage them to look at mind-body approaches. So some of the mindfulness and breathing techniques to come through there. I also encourage them to look at some forms of cold water, like, just trying to have a splash of cold water on their faces. And you don't have to go cold water swimming, but using those techniques to calm the immune system down. And I think in Scotland, that shouldn't be a problem at all in most water bodies there. I think, and then activity-wise, I'm a little bit more cautious because it's very difficult to predict who is at risk of post-exertional malaise. So I think that I'm careful about recommending activity, but I go a lot more on nutrition, and I suggest some mind-body therapies. Gentle yoga-based techniques are another thing which I talk about.
Okay, thank you. Thank you. Julie, do you have any more before we end?
Yeah, there's one more that I find quite interesting as well here, and it's zipping back more to the chronic pain and patients who've become addicted or they're on, the high dose opiate, even overdosing to control their pain and fear. How do you get those sort of patients to incorporate more healthier lifestyle? Like how do you engage them with, exploring diet, seeking psychotherapy, exercising when they're already really, really far down that journey of, medications and medicalizing, the pharmacological approach? How do you get that shift? How do you help them change?
So I think it will take a village, Julie. I'd be.
Wasn't my question, by the way, but I completely know. I have that question too. So.
Yeah, and I think it will take a village out there, and that's why I kind of think of myself as and this is where I'll be bringing in literature and research from the digital marketing and the behavior change world, and behavioral economics literature around nudging and choice architecture and those kind of words there. I did a lot of sort of reading and dipping into that world there. And I think we need to bring those principles in. And what do those principles actually say? That to bring about change in anyone, at some level, they have to be ready and wanting that change. So if you irritate somebody too much, then they are not going to want to change at all because you've pushed their biases. But if you agitate someone adequately,
doctors at that point.
exactly. So if you agitate someone, they might be ready for change. Ultimately, then to change somebody, it takes about 7, an average. I mean, Koch estimated that it takes about 7 to 8 touch points for someone to think about change, meaning that they need to hear the same information in different ways and possibly different mediums and from different perspectives to consider change in that principle there. So I think of myself as sometimes I'd be superbly lucky in that I'll be the 7th person to suggest that, and they'll think that I'm like the God, beautiful thing. But sometimes I'm just the first person to suggest a change, and they'll probably have to find their 6 other people there. So the question is, can I create a system wherein I will be part of the 7 people that will keep telling that patient that same message, that drugs or interventions or the biomedical model is not going to be adequate anymore. And that is where I think the real value for them will be there in starting to say, you know what, I need to look at other ways. And in a way, it makes me feel a little less worried that if someone comes along and I tell them, look, I have no more medication, there are no new drugs to give, and you've already had your share of nerve blocks, so there are no interventions to do, they will feel very upset and walk away from the clinic. But it doesn't make me as upset as it used to make me 5 years before, you know, that I've failed this person. I kind of think, you know what, I've given them the good advice, but maybe I was the first or second in line. But if they go and see my physio who does the same thing, then I go and see the GP who says the same thing, then they go and see their uncle's daughter's second cousin who says the same thing. Then maybe at some point the penny will drop and they'll say, you know what, he wasn't too bad. I'll go back and ask him again.
That's really helpful. I really like that approach, and I think that's quite reassuring for many of us who have those encounters with patients. And you know, we're all terrified of saying to them and feeling like that failure and saying there's nothing else I can do in that, you know, with regards to this, that, the next thing, and perhaps proposing things that they might not initially engage with. And none of us like to be the enemy. None of us like to be the patient, the clinician that they dislike. So, but hearing it from that perspective actually is really reassuring, because we can then sometimes say to ourselves, okay, I know they may not like me right this moment, it's not about me, this is helping them, and in time it might change. So thank you. That was a really good piece of advice. Thank you.
Thank you.
I mean, it's the big change that we are asking of our patients and of ourselves, because up till the 1990s, the NHS and most systems were all, you know, we'll help you, you stay passive, we'll sort everything out and correct you out. And in a short span of 20 years or 25 years, we've decided that healthcare is unsustainable, that there is too much cost involved, and now we want them to self-manage. That's a big change.
It's
you know,
a huge
if you've
change,
grown up in your first 15, 20 years, thinking that somebody else will sort your problems out when you fall ill, and then now in your 40s, you're suddenly told you got to sort it out yourself. That's a big cognitive disturbance on any of us.
Absolutely.
So I can definitely see from the patient's perspective.
Can I ask one more before we round up? Someone is asking, when should we refer to long COVID services and not just signpost to self-management lifestyle measures? So initially you're telling the patient, you do this, you know, try and increase activity, eat this, you know, at what point do you then say, right, I need to refer you to the long COVID service? I'm sure this will vary from place to place, but if you give us a bit of guideline around that, that would be great.
So the NICE guideline effectively said that 4 weeks after acute COVID. So if somebody is being left with persistent symptoms 4 weeks after acute COVID, GPs are supposed to see them, investigate and do a first set of full blood tests that the NICE guideline has talked about, signpost them to live well with COVID or living with COVID the website, and some self-management strategies. And anytime after 4 weeks, depending on how intense the symptoms are. So if people are having cardiac symptoms of dysautonomia like tachycardia, palpitations, up and down labile blood pressures, or they're having significant breathlessness, then anytime after 4 weeks, they can refer them to the long COVID service if they are having these kind of cardiorespiratory problems. If not, if they are mostly fatigue and slight breathlessness, but their initial tests are all positive or all normal, then 12 weeks is the time wherein referral to the long COVID clinics are suggested. And at that point of time, this is where it changes. So in about 70% of the long COVID services, they're all community triage services. They're all community clinics there, and they have the capacity only to offer rehabilitation. They don't have any links with cardiac, respiratory, neuro, or anything like that. So that is a challenge based on which part of England the patient is in. So in my area, if I were to comment on it, we tell the GPs that after 4 weeks, if people are having significant issues, refer them in. Okay. Otherwise, look after them for up to 12 weeks. And at 12 weeks, if the symptoms haven't gone away, refer them to the long COVID service. Our service will see all patients. Yes, there is a wait time of 4 to 5 months, but we'll see all patients. We will investigate them further if required. We'll assess them further if required. And we have links with cardiac, respiratory, neuro, ENT, whatever their symptoms might be appropriately, and then get them into a community rehab setting is the plan there. And that's what is happening in most of the long COVID services, I understand.
Thank you.
Thank you very much.
Okay, I think we will close now. We've overshot our time. I'm really sorry, but we had so many questions, and we still haven't answered all, but we do need to close now. Thank you so much, Dr. Deepak. I'll hand over to you, Julie.
Yeah, thank you so much. It was a really, really interesting talk, and going by the responses that we're getting in the messages and so many questions, I think I get the impression that everybody who logged in tonight got a lot out of it as well. So really, really valuable. I think many people who are here tonight have probably found it helpful some way or another to either their own personal experience or to how they practice at work. So thank you so much. It was really, really, really helpful. And I just want to say thank you to all of you who took the time out this evening. I know that everybody's busy. Life is stressful just now post-pandemic, or well, we're still in it. So really appreciate people that showed the interest and took the time out of their evening to join us. So can only but apologise we couldn't get through all the questions. That was just because there were so many of you and so many really inspired people with lots of questions. So apologies we couldn't answer them all. But I hope you all enjoy the rest of your evening and your week. And as I say, please do reach out to any of us if we can be of any help. As I say, you can contact Adaeze or I via the BSLM website. Deepak, I don't know if you've got any ways that you want to offer people, just if they've got any queries or questions. Don't worry, you don't have to give out your personal phone number or anything, but you know, if you want people to come via us, or if you've got any sort of resources you can direct people to.
Via you, but I'm fairly active on social media on the usual platforms. So yes, please find me through there. And as long as it's not direct clinical stuff, then happy to engage with any of the audience through the social media itself.
Great, thank you. Well, we'll let you all get on with your evenings, and we hope to see you again in future webinars. Once again, thank you very much for your time this evening, Deepak.
No worries at all. Absolutely. Thank you. Thank you so much for having me. Thank you, Julie and Adaeze.
Thank you, everyone. Thank you.
Bye-bye.
Bye.